So I just want to start by acknowledging the traditional owners of the land on which we're meeting today, the Ngunnawal and Ngambri people, and pay my respects to their elders, past, present, and emerging. And if anyone is joining us online who's not in Ngunnawal and Ngambri country, I just want to extend that acknowledgement to the traditional owners of the land on which you're joining us today. To add to that, I also want to acknowledge that the sovereignty of this land was never ceded, and it always was and always will be Aboriginal land. So today we are doing something a little bit extra. Today we're holding this seminar in honour and memory of Dr Judy Slee, who was a cognitive psychologist in RSP for many years and a highly regarded teacher and special mentor to both PhD students and early career researchers in psychology. Judy was the first ANU psychology graduate to be permitted to stay at ANU to undertake a PhD, and she was also the first psychology PhD graduate to win a Crawford Prize for her thesis. So today we're celebrating her dedication to education and to HDR students by hearing from two of our own HDR students and learning about the impact and new discoveries that they are making in their research. Now, traditionally, the Judy Slee seminars are also chaired by HDR students. We are not yet organised enough to have organised that, but if there are any HDR students who would be interested in being involved in that, please come and talk to Nicole and myself. Okay, so our first speaker is Atul Sharma. Atul is a fourth-year medical student who completed the Advanced Research Project stream in the Doctor of Medicine and Surgery program at ANU, where his research began under the primary supervision of Lillian Smythe. Atul also completed a Bachelor of Philosophy with Honours in Science in 2019 at the ANU. And today he's going to be talking to us about his research, and his presentation is titled, "Are We Teaching Climate Change in a Clinically Relevant Way?" Please welcome Atul. There's no comments in the chat to say things aren't working, so I think we can go ahead.
Great, that's a great start. Hello, can people at the back hear me just like this? All right. Let's go there. Thank you for the lovely introduction. Likewise, I would also like to acknowledge the Ngunnawal people and pay my respects to the elders past, present, and emerging. So my name's Atul. I'm a final year medical student at the ANU, and I previously completed the PhD degree in 2019. It is my 8th year as a university student. Fingers crossed, my last one. And last year I completed the long-term rural stream in the New South Wales South Coast. So it's nice to be back on campus. So the title of my talk is, "Are We Teaching Climate Change in a Clinically Relevant Way? A systematic narrative review of biomechanism-focused climate change learning outcomes in published medical curricula." So I started this research during the Advanced Research Project in early year 2, which is a research-oriented add-on to the medical curricula that hones in on key research skills. And I really value that experience, and I'd like to thank Lillian, Christina, and Diana, who helped me out with that. I would also like to thank the collaborators for this research, Lillian, Holly, Nicole, Devon, and Anna Greta. And I also realized that because of COVID lockdown and my long-term rural placements, this is actually the first time I've met Nicole face-to-face. So it's actually lovely to finally meet you. So this is the outline of my talk. It's a fairly standard outline. So my introduction will briefly go into the impacts of the health impacts of climate change and how medical schools are equipped to teach it. The second part is the current developments in climate change and medical curricula. And the third is the need to have a systematic literature review. The methods will go into developing a search term, as well as following PRISMA guidelines, as well as the extraction and thematic analysis with a focus on the learning outcomes. And as well as the limitations and next steps and the conclusion. So what prompted me to look into this topic? So just as a raise of hands, how many people here think that climate change is affecting human health now and will affect humanity's health in the next 5 to 10 generations? Great. Okay. So I don't think I really need to argue this point that climate change is a health issue. We know that it's a health issue. The WHO recently had a report that there was over 150,000 deaths and over 4.5 million disability adjusted life years lost up until the year 2000, which can be attributed to climate change. We know that it will increase heat wave intensities, to floods, to hurricanes, to bushfires, to air pollution, just to name a few. It has and will continue to cause psychological impacts at a generational level. We can frame the topic of climate change and health all the way from the cellular level up until the policy, advocacy, and population health level. So the medical school does have to cover quite a lot of breadth. The ANU Medical School's 4-year curriculum follows a typical 4-year postgraduate medical schooling, which is broken down into the preclinical phase or phase 1, which focuses on these parts, I guess the cellular to the tissue level. And then phase 2, the clinical phase, that looks at more the organ system and the human, I guess the human synthesis, and integrates that into the doctor's workflow of history, examination, investigations, and management. So climate change concepts can be integrated at all of these levels, not just the policy and the advocacy levels. So the problem is currently there is a strong demand amongst health professionals and students alike to increase climate change teaching. There is a big gap because there's no real standardized curriculum or climate change modules in our medical teaching, but there is significantly increased work into implementing climate change into medical curricula. And we want to get a snapshot of that. So why is it important to integrate climate change into all these levels? Well, medical schools at the moment generally teach at an organ systems level. And that's probably because medical specialties are also organ-based systems. So for example, you become a cardiologist or a nephrologist or a neurologist. So for example, even now, as a final year medical student, I'm on an obs and gynae term. So if we take air pollution as an example, particularly because Canberra was in smoke a few years ago, we know that air pollution causes more than just respiratory illnesses. It also causes all these other issues as well. However, these pathologies are the only ones that we know of in 2023. But what will we know in 2025 or 2035 or 2050? There is a high likelihood that there's a very high likelihood that there'll be a lot more considerations at a clinical level at these times. And I would go as far as picturing a world where there will be different therapeutic managements based on the location you're in Australia as a result of the environment at the time. I can also imagine a future where a subtopic of stroke in air pollution is a lecture in itself. So imagine if you're that poor registrar or medical educator that was told to teach this as a lecture in 5 years' time. Well, you could pray to this picture, which is the Holy Trinity, but that's not the reason why I put this picture here. I just want to go into a really good ARP snippet that was really useful to my research, and it goes into the trio of papers that are the necessary papers when you're engaging in a research project. The first thing you would do is you'll go to reputable databases, and you would firstly want to find, I guess, the most recent up-to-date literature in the topic, which in this case could be, air pollution in stroke, an updated review. You'd also need a methodology paper, which is a standardized way you can go into it, which in the age of COVID could be ways to facilitate an engaging online lecture. And lastly, you need the most recent systematic literature review that synthesizes the last 5 to 10 years of development of the research. And currently, there is no systematic literature review looking at medical teaching for stroke in the context of air pollution, obviously. But more broadly, there is no systematic literature review looking at medical education in any extreme weather event, let alone climate change. And that's the basis of this research, to synthesize a literature review to capture our current understanding of this topic. So this is going to be a text-heavy slide, but basically we know that climate change should be taught at the medical school level because it improves preclinical student engagement, allows you to integrate multiple systems, as well as the research potential. We also know that the evidence of the health impacts of climate change is ongoing, with increased evidence at a cellular level that medical schools need to refresh. And we also know that there's no systematic literature review into the topic. So the research question for my project is, what is the distribution of content and focus of the health impacts of climate change concepts taught in published medical education curricula, with sub-questions focused on the biomechanism coverage and the context in which the literature was drawn. So the first question to ask is anyone currently doing this research? So I checked key websites like Prospero and an education-specific database called the International Database of Education Systematic Literature Reviews. And this basically allows you to register your research. So if someone else is doing it, it would have been registered. There weren't any hits when typing in climate change and medical education and any associated terms. Secondly, we consulted the PRISMA guidelines to develop a standardized protocol. And the next step was developing a standardized search term, which was broken down into the population intervention outcome framework, which in this instance, I've used the Oxford Handbook of Clinical Medicine and the USMLE Step 1, which is a standardized US medical curriculum to determine the subjects. Next was inputting it into multiple databases that maximizes coverage of the literature. And because it focuses on health and education, I chose PubMed, Scopus, and ERIC. I also decided to include grey literature, which includes research or reports outside the commercial or academic publishing, because it can include government or advocacy documents, conference proceedings, and things like that, that could go into learning outcomes and teaching bodies. Inclusion and exclusion criteria were determined, mainly that the work needs to be peer-reviewed or scholarly or be reported by a professional body, and needed to include learning outcomes. We then screened the titles and abstracts for full text eligibility, and then we analyzed the papers, particularly the learning outcomes using Bloom's taxonomy. So this is the PRISMA flowchart. It looks quite intimidating. I just want you to focus on a few key numbers. So the key thing to identify is that we had 2,906 search or hits in total, which were exported onto EndNote and the duplicates removed following a standard format. Myself and another author independently assessed all these titles and abstracts, and discordant articles, for example, ones that I agreed on and the other person didn't, or vice versa, was sent through to a third person to independently review. Overall, 37 articles were assessed for eligibility and 11 papers were found suitable. So let's go to results. So there were 4 broad themes with one sub-theme. The first theme was knowledge of health, environment, and their relationship. The second was the impacts of climate change on epidemiology, health risks, and their presentations. The third is the impact of climate change on health systems. The fourth is adaptations and changes to clinical practice, with a focus on leadership and advocacy that medical students and residents can follow. Here is the first part of the results. We identified 361 learning outcomes across all the papers, and 92 of them were related to biomechanisms. Generally, most of the literature was targeted at the medical student level, which includes all of these, but there were 2 papers that looked into postgraduate medical years. So Philipsborn was looking at climate change curricula for residency training in the US and provided learning outcomes that actually aligned with the medical education core competencies. And Valois, I think if I'm pronouncing that correctly, was looking at assessing doctors' knowledge of climate change using set learning outcomes. They had a higher proportion of learning outcomes related to biomechanisms, along with Rabin and the Canadian Federation of Medical Students Association. The last one was the only paper that had a subsection dedicated to Indigenous health. Overall, we can see that there is a fairly high spread of the learning outcomes, ranging from 8% all the way up to 55%. This is also a fairly text-heavy slide. These were the topics that were covered in the learning outcomes. So for biochemistry, we had micronutrient deficiencies and malnutrition. For cardiology, there was a broad coverage of cardiovascular diseases. For dermatology, there was atopic dermatitis and skin cancer that were mentioned. Gastrointestinally and infectious disease were the most prominent focuses, explicitly going into specific pathogens and infectious diseases. But I'm sure that we'll actually learn a lot more in the years to come. Hematology and oncology were not covered, and I'll go back into that a bit later. And just continuing on, musculoskeletal was also fairly brief, kind of just going into physical trauma. But what does that include? Does that include fractures, dislocations, ligaments, tendinopathies, what type of fractures and where those fractures are? Because that will actually guide management of sending the right specialist staff in those areas. For example, an ED physician or an orthopedic surgeon, etc. We also know that for neurology and neurosurgery, cerebrovascular disease covers a lot of things. So what does that actually mean? And pharmacology and toxicology generally has significant overlap with the other topics. Psychology and psychiatry is fairly interesting. It does cover a broad base. Personally, I'd be interested in knowing the link of extreme weather events on psychiatric illnesses such as schizophrenia, bipolar disorders, eating disorders, and even emerging personality disorders in climate-prone areas. Pulmonary or respiratory also had broad coverage, as well as the renal and the reproductive systems. So the first thing to note based on that tables is that the learning outcomes have limited coverage of the health impacts of climate change on the less dominant systems. So if we go back to our original diagram, which goes into the health harms of air pollution, basically the literature only covers around half of that. So that actually excludes a good amount of the neurological, gastrointestinal, gynecological, or even the renal developments, which isn't even on the slide because it's still quite new. Now, if we're analyzing the learning outcomes through Bloom's taxonomy, so Bloom's taxonomy is just this diagram on the right, which goes into, I guess, the key terms, remembering, understanding, applying, analyzing, evaluating, and then creating. And our results demonstrate that most of the content is at the understand level at 47%. And in one way, this makes sense because this entire topic is fairly new. So you would rather pitch it at an understand level rather than an apply level. The remember level is low. And personally, I think that's a reflection on the current state of climate change curricula, which in many ways is an add-on to existing curricula. So remembering of the facts is left to the dominant curriculum, and the understand term is trying to relate those facts to climate change. I do think that future curricula will have more set at a remember level as we continue to learn more about this area. The fourth finding is that subspecialties like hematology, rheumatology, and even immunology are not mentioned. This is important because we know, for example, that there will be populations at greater risk of anemia just as a result of changing agricultural patterns, particularly in rice crops. We know that flare-ups of autoimmune conditions like lupus or rheumatoid arthritis can happen in extreme weather events. And personally, it's one thing to say these can come under nutritional deficits under the biochemistry and nutrition topic, but I don't think that's enough of a reason to justify just omitting an entire subspecialty in medicine. And there's emerging evidence that shows that there will be an increased incidence of blood disorders such as thrombocytosis and even leukemia. Lastly, analysis of the authorship of the papers show that the vast majority are from the US, the UK, Canada, and Australia. Most of the authors have a medical degree or a population health degree or both, but most of the world is omitted. These are the only countries that have representation in this topic. And it must be noted that the majority of those authors actually originated from one paper. So this is a problem because we are potentially excluding the voices of countries that are particularly climate vulnerable. That's not to say that Australia isn't climate vulnerable. We are the most climate vulnerable in the OECD. But I think based on this topic, we need to ensure that medical education remains equitable, context sensitive, and locally driven. So what are the limitations and next steps? The first limitation is that there is significant publication bias because most of the curricula that is being taught, assessed, and evaluated does not go through to the published literature. And this is despite us going through the grey literature as well. So I'd say the first recommendation is to improve primary data collection to provide a more comprehensive overview of this topic. The second limitation is that the papers are limited to English, which may increase the publication bias. So the next step is to include papers that are not in English. So here, what are the conclusions from this research? The first is that biomechanism related content represents around 25% of the total learning outcomes, and it has a significant focus on infectious diseases, air quality, and extreme heat, but there's still significantly large gaps in the literature. The published learning outcomes represents, or it's only really the tip of the iceberg, especially as there is emerging evidence on this topic moving forward. And lastly, we need to have greater engagement with non-Western and climate vulnerable medical educators. I'm really proud to say that we submitted this paper for publication. So thanks to everyone that was involved, and I'm happy to take any questions.
Great presentation. I guess my question is, and you can like draw on your own experiences, how you can see this like being applied in like the real world. So like if someone was going to the doctor, like how do you think it would like you see that like climate change and then like the symptoms that they're presenting, how they interact?
Atul, can you just repeat that first? Yep. So just for people in the audience, the question was, how would this project be practically implemented, I guess, at a clinical level? Let's say if I'm the doctor and there's a patient in front of me. So there's a few things that this can be useful for. I think the first one is health literacy and improving health literacy. So let's take, for example, the bushfires that happened in Canberra a few years ago. So there were, I know anecdotally that there were patients, particularly pregnant women, that were coming in during the smoke and going to their GP and saying, okay, this smoke is bad. Is it going to impact my baby? And we actually don't really know in Canberra. So what doctors and particular researchers have to do is look at the literature and almost kind of go to that diagram that I was talking to you earlier about, as in there may be an increased incidence of these certain conditions, but this is the way we can manage it. So that's the first thing. I think the second thing, I guess more broadly from the clinical level, is I guess management of healthcare systems. And I think if we frame climate change in medical schools at a systems level, then students that are, let's say, really gunning for cardiology or really gunning for orthopedics or really gunning for endocrinology, because Chris Nolan's here, if they have an understanding of the health impacts of climate change for that specialty, then it would lead to a greater retention of that knowledge so that they're able to pass it on after medical school. Does that answer your question?
Yes, thank you.
Doctor?
Something that didn't come through there was elements like social cohesion. How does climate change sort of crises sort of affect how people interact together, family dynamics, etc., etc. Was there any of that here?
So when I was looking through literature, yes, there was significant elements of how climate change will disrupt systems and I guess that social cohesion element, be it through extreme weather events that impact hospitals, to, I guess, greater migration and migratory changes, to even the more indirect things like an increase in conflict in climate-prone areas as a result of, resource shortages. Generally, the literature breaks it down into the direct impacts of climate change, such as some of the ones mentioned, as well as the indirect impacts, which goes to that. So yeah, there was coverage.
So I'm very involved with the Child 2020 study, which sort of really came out of bushfires and looking at pregnancy and health. In that study, it's actually a real challenge to sort of work out what the physical health effects of bushfires and bushfire smoke is, because by the time you get ethics organised, etc., the fires are gone. But there were clear evidence comes through from our study about the psychological mental health signs of climate events, post-traumatic stress, depression, anxiety problems, but also the effects on particularly families, disconnect from access to health services was a real issue that was compounded by COVID, that came soon after that. So it's easier to sort of collect data, I think, on those aspects. The actual having good evidence of what the physical impacts are is a real challenge for us. But at the medical school, we look to sort of in teaching medical students about climate and health, I think making very clear what the gaps in evidence are, and you get then clever young people that actually work out ways to find solve those gaps. So that's another really important aspect of curriculum, etc. Make people aware of where the gaps are, and we need help to do research to fill those gaps.
Thank you. Any other questions?
One quick one. I was just wondering what your plans are for getting like primary data. Like, for instance, have you thought about very locally doing like an audit of the change content in the ANU medical school or like anything like that?
Yeah, so the question for the Zoom void is what are the potential next steps of implementing this research? Like, would you consider doing an audit of the climate change curriculum in ANU, or I guess next steps afterwards? So one of the, I think, practical next steps once this research is submitted is reporting the findings to the global medical education and climate change body that exists, the Global Consortium of Medical Education and Climate Change. I think that's the fancy term for it. And a lot of the authors that are contributors of some of these papers are also in that body as well. So I think disseminating our research to them could be a really practical first step. In terms of, I guess, the ANU medical school curriculum, we do actually have a really good one. It's the planetary health module, which is in our transition block, our block 7. And it does go into the direct and the indirect impacts of climate change. Although this research was kind of going a bit more comprehensive and trying to look at all the learning outcomes.
Well,
Thank you.
bear with us while we do a switch over the tab.
Do a situation. Yeah. Oh, look at all these people. Do you want to just
Yeah, sure. People hear me? You. And
yeah, the chat gone. Okay, like no.
yeah.
Go back. I would like everyone to appreciate my colour scheme, by the way. Very important to me. I think we're okay.
You can repeat your
Okay, let's start again. So round 2 of this. Hello everyone, my name is Aseel and I'm a 3rd year research PhD student in psychology. And as Joe stole my thunder, yes, I'm making the same joke twice. This is the first published study of my PhD, and I'm not going to repeat the very long title because you can all see it on the board, and Joe's also said it. Maybe.
Might need to use the arrows.
Okay.
No problem. If there are arrows.
Oh, okay. So again, before I continue, I also wanted to acknowledge and celebrate the Ngunnawal and Ngambri people on whose land we are meeting on today, and pay my respects to the elders past and present. I would also like to extend this respect to any Indigenous individuals in the room today. So here's our agenda, very stock standard as well. I'll start with some background information and then show you how we came to the gaps and aims of the review. I will briefly go over the methods because I have a lot of results that I'll be discussing, and then the implications of these results and future directions. So over the past few years, the word uncertainty has been thrown around so much by the media. Anytime you open the news or read an article online, it's likely to contain the word uncertainty. Makes it kind of hard to have work-life balance when you're just trying to mind your own business at home and the key word of your PhD keeps popping up. Now, we know that the whole point of the media is to make money and I guess keep us informed. And while uncertainty can be fun, like a surprise birthday party or hearing your favorite artist's new album, like the media caught on, uncertainty can be pretty scary and scary news sells. So with an interest in these negative feelings, some researchers have looked to those who react strongly to uncertainty. These individuals are incapable of enduring unknowns, which is referred to as an intolerance of uncertainty. Now, research consistently shows that higher levels of intolerance to uncertainty is associated with a range of anxiety and mood disorders, from generalized anxiety disorder to panic disorder to major depressive disorder. Thus, it's widely considered to be a transdiagnostic factor across emotional disorders. But like any good researcher, understanding why intolerance of uncertainty is related to emotional disorders is an important endeavor, especially for interventions. So, emotional disorders are often accompanied with difficulties in regulating emotions. Uncertainty is associated with a range of negative emotions, from fear to distress, in individuals who are intolerant to uncertainty. Therefore, the ability to regulate emotions effectively or not may play an important role when coping with uncertainty and managing these emotions. So in other words, understanding whether and how intolerance of uncertainty is associated with emotional regulation is important and the whole point of my PhD. So emotional regulation is defined as the process in which individuals modify their initial emotional experience by employing emotion regulation strategies. Emotion regulation strategies can be tentatively grouped into either adaptive or maladaptive emotional regulations. Now, caveat, I'm aware that being effective at regulating your emotions is not about never using rumination or suppression, but instead being flexible with your application, depending on your situation and your emotions. But in the context of uncertainty, generally negative emotions, and emotional disorders, research and theory does allow one to categorize and distinguish strategies between these two labels. So now, what's the evidence that connects these two constructs together? Firstly, theory. Looking at 3 different models of intolerance of uncertainty, we find evidence of a range of different maladaptive strategies, such as situational avoidance, experiential avoidance, thought suppression, reassurance seeking, and rumination. Now, these papers that the models come from also briefly mention adaptive strategies that aren't used frequently, such as acceptance, cognitive reappraisal, and problem solving. Moving to empirical research. Research from several individual empirical studies also support the ideas of these 2 constructs coming together. Importantly, while the models propose adaptive strategies that aren't being used by these individuals, when you try to research each strategy with intolerance of uncertainty, you're not going to find much result, as you can see from the screen. In particular, the term adaptive emotion regulation strategies isn't yielding a lot of results. And we also see a lack of experimental studies in the research. So taking evidence from both theoretical models and empirical studies, we see 2 main gaps. 1, we don't know the strength of the magnitude between each strategy and uncertainty is. And 2, we don't know if all strategies contribute equally or if some are more important than others. And this is theoretically key because some strategies are reported by multiple models, while others are only reported by one. So therefore, and in academic terms, the aim of my meta-analysis was to systematically investigate the relationships between intolerance of uncertainty and both maladaptive and adaptive emotion regulation strategies. Since we were interested in whether certain strategies were more influential than others, or if they all contributed equally, I conducted subgroup analyses on only maladaptive, on only adaptive, and on all types of strategies together. We also ran moderated tests for age group, the clinical versus non-clinical status, and study design. So I registered the study in October of 2021, and I used 4 databases, PsycInfo, PubMed, Scopus, and ProQuest to search for relevant articles. The inclusion criteria were studies needed to have the potential to report a bivariate relationship between the concepts. Both concepts were measured with a standardized scale, meaning that it had been pre-validated and not created by the researchers in their study, and of course, using human participants. So here's our beautiful Prisma flowchart. 2 reviewers were used at every stage, with me being the constant reviewer, and we concluded with a total of 91 articles, so 161 correlations for analysis. So results. Let's start off with understanding the basics of the literature. Of the 91 studies, 35 of them did not report the original results we needed, and after emailing them and requesting it, 14 of them got back to me. With the moderators, overwhelmingly, the studies were using an adult sample. Most had a non-clinical population, and a majority were correlational. We found 13 unique maladaptive strategies in comparison to 9 adaptive ones, with rumination being the most studied. With our biases, we tested 3, and reporting bias was found to be significant. This means that there was a difference between the studies that originally reported the correlation and those that did not. One possible explanation is that most of these data points are coming from correlational studies, and then of those studies, most of them were coming from the correlation table. And so sometimes that isn't reported in a paper, and that may be due to journal constraints. Our first result. So I found a moderate and positive effect size between maladaptive strategies and intolerance of uncertainty, coming at 0.41. We found no publication bias, which is great. But as you can see, we did end up losing a range of studies for the subgroup analyses, and you'll have to wait a few more slides to see those results. Now, we lost them because we used the rule of thumb of removing subgroups that did not have at least 5 data points, as this can make the analysis unstable. Moving to adaptive strategies, we found a moderate negative effect size coming at -0.24, but sadly, we found a publication bias, which means that the effect size may be overestimated. And again, we lost a bunch of strategies in the subgroup analysis. For moderators, none were significant, which is great, but we have to take this with a grain of salt, as only the study sample 1 could be done for adaptive strategies. And even within the study design comparison, we actually had to remove a subgroup for the maladaptive strategies, which was the intervention / treatment 1, since there were only 3 data points. Now for the results we've all been waiting for. So when we compared the 2 results, I first had to recode the adaptive strategies so they could all be going in the same direction. And we found that 1, there was a difference between the 2 types of strategy categories, and 2, this effect is larger for maladaptive strategies. Specifically, we find that cognitive avoidance had the biggest, coming at 0.53, and expressive suppression had the smallest and non-significant result. Now, if you're wondering why there's a negative sign for the adaptive strategies, it's because these numbers were the exact same when I did recode them, and so we don't want to repeat ourselves. We kept this table, but we said that these were all going to be positively associated. So how did our findings compare to the theoretical models and empirical evidence? Quite well. So with maladaptive strategies, where they were in line with existing models and previous research. However, it's important to note that strategies such as reassurance seeking, which had been present in a model, we could not study. For adaptive strategies, they were in line with empirical evidence, but mindfulness is actually not mentioned in any of the models. And so that obviously has implications for theory. And then with comparison, the effect being larger for maladaptive strategies is in line with the theoretical models. So with an explanation for why we found certain results, for cognitive avoidance, by definition, it's used to escape thoughts about undesirable situations and problems. If you score highly on intolerance of uncertainty, then by default, among other feelings, you're going to find uncertainty undesirable. And so it makes a lot of sense that these individuals will be using this strategy, and it's reflected by our results. In contrast, for expressive suppression, it's used to inhibit overt facial expressions as the emotion is playing. So for example, holding back laughter, holding back your tears. It's unlikely that overt expressions are the way these individuals are going to express their distress in an uncertain situation. And so it makes this strategy not very relevant to them, and we see that in the results. Now, one thing to note is that cognitive reappraisal had our smallest and significant effect size. And you might be like, why? There is research that shows that if you fail to reappraise effectively, you end up feeling more stress. And I would say that reappraising uncertainty will be quite challenging, as you're going to need more information to switch from uncertainty to certainty. So it might not be so relevant for these individuals. And this, of course, then has implications for the uncertainty models that report it. So more implications. First one is emotion regulation is important for intolerance of uncertainty. We know that certain maladaptive strategies are more important than others. And overall, these individuals are less likely to use adaptive strategies. So these results highlight the importance of including both types of strategies in the models, instead of just focusing on maladaptive strategies and like adding adaptive strategies at the end. In terms for practical implications, we now know which of the strategies we want to increase and which one we want to decrease, being cognitive avoidance and mindfulness, respectively. And so no research is perfect, but instead of describing them as limitations, we can use them to drive future research. So like all Western science, there lacks an acknowledgement and integration of research coming from anything but Western countries. So all of the studies here were reviewed in English. So future research in this area needs to integrate linguistically diverse studies, which automatically means bi or multilingual research is being needed. We definitely need more studies investigating the strategies that we could not run the subgroup analysis, with a particular focus on adaptive strategies, since we want to know their buffering effect. And in terms of on a more sample level, we want to know how this relationship works with a child and adolescent population, as we know that emotion regulation skills develop over time. And so if you want to make appropriate targeted interventions, you need to have the research. And of course, as all things, we need more experimental studies to test this relationship for causal matter. So in conclusion, this meta-analysis was the first to investigate the relationship between intolerance of uncertainty and emotion regulation. We found that maladaptive strategies had a stronger relationship, and this supports the theoretical models of uncertainty. We also found that more research is needed to be focused on adaptive strategies, both theoretically and empirically. And then we found out, preliminary results, that we should be intervening on cognitive avoidance and mindfulness. So thank you for listening. That was a probably 15-minute talk on a 48-page paper. Any questions?
Any questions?
Well.
Yeah.
So I realize this is a correlational paper, but do you have a theory about causal direction? Do you have a model of how you think the two might be related?
Just repeat the question.
So the question was, this is a correlational paper. Do I have a theory about what the direction would be? So we are doing obviously further research with my PhD, kind of trying to figure it out. I'm putting emotion regulation as a mediator. And so all of the intolerance of uncertainty models show a kind of like cyclical relationship where if you don't deal with the uncertain situation, you're going to continue not liking it. And so my argument based on like the theories and the papers I've read, it would be like, these people don't like intolerance, but like they are intolerant to uncertainty, they don't like uncertainty. They get into an uncertain situation, they're feeling all these emotions, they start regulating it poorly, which means that their like negative emotions are continued to be experienced, and as a result, they are like have the reinforcement, the idea that uncertainty is not great is reinforced, and it just keeps going and going. And so that's what I would say. One thing to note is all of these emotion regulation strategies are never called emotion regulation, right? They're like rumination or avoidance. And I'm like, yes, but also you should name them what they are. So I think that I would generally be putting it as emotion regulation or emotional dysregulation alongside other things like anxiety and worry. I'm not saying that they're not important, but my other studies are trying to look at which of the strategies are important. So, yes.
We have one online. Can I just go down?
Yeah, so I was going to say, like, how do I, where are they? Let's see if we can get this word. That's option. Yeah.
Purnima, did you have a question? You might be able to unmute and ask it. Otherwise, maybe pop it in the chat for us.
Yeah, no, I did want to ask a question. And this is a complete lack of understanding. Can you hear me? Can you hear me? Can you hear me? Can you hear me?
Purnima, do you mind popping it in the chat for us? Is that okay?
Sure.
Sorry. Do we want to go to
So I recognize that the papers were all about adults, but you also mentioned that in future directions, it would be good to see it in children. So I'm wondering, because as you say, there's these skills developed over time. How can we catch it? How can we be early on? How can we develop the important skills for children or young adults? And maybe because there is a lot of stress as we grow up, especially teenagers or early adulthood. So is there anything out there that's already there, or can this research help developing strategies for it?
To repeat the question, it was how, again, most of these studies I mentioned were based on adults. And of course, I talk about how the importance of looking at how children and adolescents are reacting to these as you get older, more stress is happening, more uncertainty you're experiencing as well. So we want to catch it early, and whether I've seen anything that kind of covers it. I don't think I've seen anything. Even like, yeah, I would say the interventions and treatment papers I've been reading are all again on adults. So I'm going to answer this based on my opinion, based on everything else I've seen. I think generally we need a more focus on emotion regulation for children. Like, we know emotion regulation is associated with psychopathology. And of course, I'm not like coming for the children. They're like developing their brains, and they just don't understand kind of what's going on. Oh, that's a good question. Sorry. And so I think that kind of having this discussion about what are you feeling, right? And you're like, maybe, because we know children as young as 10 are worried about climate change, right? And that is uncertainty as well. So getting them to be able to describe and define what they're feeling, and then teaching them how to cope with that. I think that generally when it comes to kids, they say it's the parents or the primary caregiver and their strategies and how they can handle their emotions, because then they're like modeling that. So I guess that if we wanted to run an intervention, it'd be like improving the caregivers' emotion regulation and their emotion regulation literacy. So I hope that somewhat answers the question. Now for our chat, that's a great question. I think generally, though, what they say is it's like the reverse. So what it means is that in the short term, a strategy isn't maladaptive. So for example, they would say that if you are like in a work environment and you start getting really angry with your boss, obviously you have to like suppress that emotion. You can't just implode. But over time, and I think a lot of people would have this, if you are in a workplace that is bringing up so many negative emotions and you just keep suppressing them, it's going to come out in other ways. It can come out in terms of your physical health, and again, also your mental health. So I think that's kind of what we end up saying. Besides cognitive reappraisal, I don't believe there's literature to support things like problem solving being like short-term good, but long-term bad, unless you kind of assume you can problem solve your way out of anything and then don't like think about other strategies. And so I guess that's why I mentioned how proper, like effective emotion regulation is your ability to switch and like use different strategy. But unfortunately, at this point, we haven't really created a scale or a good understanding of how to measure this in people, besides maybe having them in like come into a lab and then see them react. And of course, that becomes artificial. Yes, tell me in the chat if that answered your question. Anytime. That might be flash drive.
We
Does
have
anyone else have
time
any questions?
for 1 or 2 more questions. I have one.
Yes.
So I was just wondering if you could tell us a little bit more about the future studies that you're planning to look at, I suppose, the causal directions and also the buffering effect of adaptive strategies.
Yes, love that. That's a great question. Actually, my friends asked that. And so the second study of design session will be adaptive long term. Hold up to finish this one. No, it'd be the reverse. So ignoring a stressor would be only good in the short term, but you will have to deal with it, unfortunately, in the long term. And I think that any therapist in the room would agree with that. Yes. So with what I'm doing next, currently I'm in the process of getting feedback on my second study from one of my panel members, where we run a longitudinal study. So I was like, I want to know in time 1 what your intolerance of uncertainty levels are, and then chucked in 8, so all of the significant strategies into time 2 as a mediator. However, we did include reassurance seeking because it's theoretically key, even though we didn't have empirical evidence. And then in time 3, we were looking at anxious symptoms, depressive symptoms, and negative affect. Unfortunately, I don't have enough money to make it into like a structural equation model where they made like a latent variable of emotional difficulties. So we just ran 3 big mediator tests. And guess like a little like spoilers, what we found, rumination, like when you have them as a competing model, only rumination and experiential avoidance were the significant emotional regulation strategies over time. And with caring about buffering effects, experiential avoidance comes from like acceptance and commitment therapy for my non-psychology people. And so Hayes has said you can actually recode that variable to the acceptance. And so my third study is going to be investigating if we do kind of decrease rumination, increase acceptance, what's going to happen? So we're just waiting for ethics right now.
Super interesting.
Do you have a quick
Yeah,
follow-up?
that's a very quick question.
Yes.
In your literature searches, did you come across cultural differences in adaptive and maladaptive strategies?
Not see, I did get papers from like people who were like have the half paper in English and half paper in like Persian, but I can't remember there being a huge difference in like the association being positive or negative. But then again, I've looked at them so long ago. So I can't tell you off the top of my head, but I would assume that, and I think you can assume that more on like a parent to child. Like we know that different cultures have different ideas of like emotions and how to like cope with them and express them and things like that. But I don't want to also generalize because everyone's different. Yes, so it's important to look into other cultures. Yes, I wish I could read science in Arabic. Sorry, mum and dad. I think I should leave.
Yeah.
Yes.
All right, thank you so much, Aseel. So that brings us to the end of our seminar for today. I just want to let you know that we should have tea and coffee and biscuits or cakes or something delicious outside for those in person to enjoy. And next week we have a special seminar. It's going to be an hour and a half long, so 3:30 till 5 in Canberra Cinema, where Aseel Sahib and Micah Kamada, two of our PhD candidates, will be leading us in a discussion about cultural safety in the classroom and how we can improve that. And that'll also be supported by Associate Professor Tegan Cruz and Dr. Olivia Evans as well. And then we'll have drinks at Badger again afterwards. So please do join us for that. And we should have an online option as well. So yeah, and that's it. Thank you to our speakers again.